Good morning to everyone and welcome to today's session. Piyankar, Sairam, Bhargava, Vaibhav, and many more who are all online. Our season for 2021 has started. As a part of it, 45 Sundays, morning 9 a.m. to 5 p.m. Don't worry, it's not just only me. There are many more other teachers also going to take these revision sessions to inspire you to prepare. So let's make the great beginning. As a part of these 45 Sundays, we have started with anatomy on this auspicious day of Republic, Jan 26th. So let's make the great beginning. So today we are going to discuss 25 very premium high yield topics in anatomy as a quick revision, right? So first let us take a quiz and you exercise your thought process. After the quiz is being done, we will be going for the discussion. So every time it is like 30 MCQs quiz followed by 1 hour discussion, then 30 MCQ quiz, then 1 hour discussion, so that you are proactive in answering the questions. So let us make the great beginning. Are you all ready? Vaibhav, Piyankar, Sairam, and everybody who are all online. So keep punching the answers, Doctor. Tapashpal, Nagambika, and many more. Please punch your answers. Every 30 seconds, the question will be changing. And this is all your show. After you finish answering the questions, I'll be joining you for the discussion. Every 30 seconds, one question will be changing. Please take a good amount of time in order to answer the questions. So first 30 questions, 15 minutes ke baad, I'll be joining the discussion, right? Good evening, good morning, everybody, and a great welcome to all of you. From good morning to good evening, 9 a.m. to 5 p.m., we will be going through a marathon race of some of the favorite topics, favorite questions, hot stock for the examiner for the today's exam. So, I hope you all like this pattern. First, you need to be challenged in order to pay attention. So that is the reason first we give you around 30 MCQs, challenge your beautiful mind. Extempore, you will answer some question, some answer, and after that we have a discussion. And always keep a 200 pages notebook so that whatever that you felt that you need to do a revision, you can make a note. Always personal notes is the best notes and a great companion in the tomorrow's exam. Dipendra, Vivek, and many more who are all online. Hope you are all ready for that long journey today. Now, doctor, ear, anatomy of ear is one of the favorite high-yield topics for the examiner. Keep punching the answers one more round. Infection of the CNS. It spreads through the inner ear through the cochlear aqueduct. Good to see Roshan Yadav. So we have semicircular canals, you all know. This is the utricle. Then you have an endolymphatic sac. And this is the saccule, scala tympani, scala media inside it. Then this is the scala vestibuli. And here you have the CSF. Now the examiner's question, how does the CSF basically spread? It is through this cochlear aqueduct it will be passing. This is the cochlear aqueduct which enable the CSF to pass. That is what you need to remember, where the middle ear infections can spread into the brain and can lead to development of meningitis. One of the very common causes is the otitis media, is what you should remember. So what is cochlear aqueduct, doctor? The scala tympani is connected to the CSF through this cochlear aqueduct. It's a connection between scala tympani and the CSF. And endolymphatic duct is basically formed by what? It is the union of saccule and utricle. So you have the utricle here, you have the saccule here. The both ducts unite and they form the endolymphatic sac, whose dilatation lead to the development of Meniere's disease. Hydrops of endolymphatic sac in Meniere's disease. Then in case of Meniere's, how do you treat it? You do a shunt operation in order to let the drainage of that hydropic endolymphatic sac in case of the Meniere's disease is what you should remember. So here you can see Retal's fissure. So what is meant by Retal's fissure? Let's talk about it. It is also called tympanomeningeal hiatus, is the name which is being given for the Hirtl's fissure. Now, it is an embryonic remnant. This Hirtle fissure is an embryonic remnant, and it connects the CSF space to the middle ear, just anterior and posterior to the round window. So, normally this Hirtle's fissure get obliterated. That's the point you need to appreciate. Endolymphatic duct drains into. Now punch your answers, doctor. Punch your answers. So, unlike a face-to-face class where you cannot really express much because there's a huge crowd sitting, here you can punch your answers. You can go wrong, you can go right. That's how this is much more. Live online is all the future of learning. So, Vaibhav Mittal is proposing saccule. Saccule, come on, everybody. Roshan also is saying saccule. Endolymphatic duct, it drains into subarachnoid space. Just before we have seen, no doctor. Typically, endolymphatic duct is formed by the union of saccule and utricle. And ultimately, where does it drain? Right? So, inner ear, from where does it arise embryologically? It is from the otic capsule. Which structure attains adult size at birth? It is the otic capsule. So, otic capsule and mastoid and petrous part of the temporal bone, here you are having the otic capsule. You should remember. So, one quick look of the structures in the ear. See, doc, this is external ear. This is all middle ear. And you have the inner ear. In the inner ear, you have the cochlea, semicircular canals, then internal auditory meatus, and the facial nerve will be passing very close to that, and it will be passing and descending down and exiting through the stylomastoid foramen. And this is the otic capsule. And of course, this is temporalis muscle. So, otic capsule ossification, it typically starts at 16th week. It is completed shortly before birth, and it achieves the adult size right at the birth. And it has a very minimal modeling throughout the life. That's what you should remember. Pinna also is fully formed at birth, but it achieves the adult size by 5 to 6 years. That is what you should remember. Now, doctor, punch your answers. Which will attain adult size before birth? Adult size before birth. The ear ossicles. Which artery does not supply the middle ear cavity? Posterior auricular, posterior tympanic, stylomastoid, they all supply the middle ear but not deep auricular. So here we need to know a bit of maxillary artery branches, one of the favorite question for the examiner. Maxillary artery has a first part, second part, third part. So in the first part you have deep auricular, middle meningeal, inferior alveolar, anterior tympanic, accessory meningeal. Somehow you need to remember this. Whether you go for USMLE, foreign medical graduate exam, or you are taking your anatomy first year exams, this is the short notes. You have to be very sure. Then second part, deep temporal, mesenteric, pterygoid, buccal. Second part. Third part, posterior superior alveolar, greater palatine, artery of pterygoid canal, infraorbital, pharyngeal, sphenopalatine. Sphenopalatine artery is the terminal branch of the maxillary artery. So this kind of things what you need to do, doctor, last moment revision के लिए अपने आप का एक notes रहना चाहिए, right? So in the 200 pages notebook, you need to make a note that in the last moment, let me promise myself that I am going to do the revision, right? Whether it is a NEET PG exam or whether it is life in general. From 40 to 60, which is called middle age, if the guy is regularly exercising half an hour every day and quit all the habits that he had until 40, he is well prepared to live from 60 to 90. Human longevity increased. So similarly, Vivek is asking, sir, please make some mnemonic for this. Simple, doctor. First part is all about somewhere nearer to ear and head. Auricular means ear. Meninges are in the brain, right? Then anterior tympanic, accessory meningeal. So they're all more on the head. Second part comes a little bit around the mouth. So you have masseteric, buccal, pterygoid, deep temporal, which typically constitute the second part. Third part is all inside the mouth. You have pharyngeal, sphenopalatine, greater palatine, artery of pterygoid canal, superior alveolar, infraorbital. They all typically are the third part. It's only a question of 3 to 4 classmates in the reading room. You do a revision of this first part, second part, third part. Once more before exam, ek martaba revision karo, bas, more than enough. But this is one thing, any exam you go, NEET PG, FMGE, AIMS or anything, which is a second part branch, which is a third part branch, they keep on asking the same question, right? So that's very important. So deep auricular is the branch of the first part of the maxillary artery. It arises with anterior tympanic artery. It ascends in the parotid gland behind the temporomandibular joint and it pierces the cartilaginous and osseous wall of the external acoustic meatus and it supplies the cuticular lining. So that is what you need to remember. So the examiner's question is, which artery does not supply middle ear? Deep auricular is only until outer ear, not middle ear. Whereas posterior auricular, posterior tympanic, stylomastoid, they're all the middle ear is what you need to understand. Now, doctor, supra-meatal triangle, where do you find it? Above the mastoid anthem, you have the supra-meatal triangle. So the mastoid antrum is full adult size by the time at birth. And it is covered by 3 millimeters of petrous bone deep to the floor of the supra-meatal triangle. That's the point you need to appreciate. So let us look where is supra-meatal triangle. You all can align yourself with your mastoid bone. Are you feeling the mastoid bone? Yes, sir. Mandible? Yes, sir. Between the two, you have external acoustic meatus? Yes, sir. Here you have the root of zygomatic bone. So in this area, this is called spine of Henle. So you have the inferior temporal line, then your mastoid bone, and the spine of Henle of the zygomatic, root of zygomatic. Here you are having the McEwen's triangle is what you need to remember. So you have a temporal line and the typically the McEwen's triangle. So the boundaries of the McEwen's triangle is the favorite question of the examiner. So anteriorly, it is the posterior border of the external acoustic meatus. Superiorly, it is the posterior root of zygomatic arch. Posteriorly, the line which is joining the two. Typically, this is how the McEwen's triangle is typically created. Now, the next favorite question of the examiner, topic of the examiner is rectum. Fascia of Waldea, where do we see? Between the rectum and the sacrum, we have the fascia of Waldea. So, you need to have a clear orientation towards the three-dimensional anatomy of the pelvic structures, doctor. So, once you form that three-dimensional orientation, no one will stop you. Doc, you have the bladder and the urine is passed. Prostate is waiting here. Right? Now, this is the fascia proper. You can see that. Fascia proper. Fascia proper. This is the rectum and anal canal, and this is the mesentery behind the rectum. Mahipal is asking, sir, is this video is available on MBBS, online MBBS video library? Oh, why not? See, today we made it a complimentary session for everybody, right? It's an indirect way that we are advertising that, guys, you please join us. So, from next Sunday onwards, we will have the broadcast only directly into the onlinembbs.com only. Right? So, 45 Sundays, you get 360 hours of revision in 2 cycles. First cycle, 21 Sundays, 19 subjects, khatam. Then 24 Sundays, 19 subjects, second cycle, khatam. By November 30, 45 Sundays are there, we finish 2 rounds of revision, right? So, even you joined a little late also, you have another round to join. But the beauty part is all this video is made available in the onlinembbs.com video library. All these PowerPoints of notes is also available. 2 lakh PowerPoint slides are there. You don't need anything else except consuming all these 30,000 MCQs, 953 topics on the onlinembbs.com video library, comfortably sitting in your home, participating in these interactive sessions. Right now. So, this is the mesorectum. So, this is the three-dimensional anatomy you need to be very sure about. So, doctor, this is the bladder. These are the seminal vesicles. You have the rectum, you have the mesorectum. Then here comes the fascia of Denonville. Fascia of Denonville. This is the middle rectal artery, the lateral ligament, the fascia propria of the rectum, and this is called presacral fascia. These are the presacral veins. You can see this is the pelvic wall, and this is the pelvic plexus, and here you have the superior rectal artery, and here you can see middle rectal artery. Middle rectal artery. एक आंखों में चमक गया ना? This gone and sit in your mind now, because tomorrow when we discuss surgery also, it is very important whether you have an orientation to this image or not. is very, very important. Now, doctor, what are the supports of rectum? Rectovesical fascia of Denonville. So it extends from the rectum behind it to the seminal vesicles and prostate in front of it. So you can imagine you have the rectum behind the fascia of Denonville. And here you have the bladder and seminal vesicles in front of the fascia of Denonville. Rectum is behind that is posterior to the fascia of Denonville is what you need to remember. Abhishek is asking, sir, what about one-liners is also there? Everything is there, doctor. Everything you have on the online mbbs.com video library. But still, to read a book, to listen a video, you require motivation. So, my job is to come live online, spend time with you all wonderful guys, every day, every weekend, become your classmate and inspire you to study. That is the job of me across the year. Of course, there are many other teachers also who are also willing to come forward and spend some interactive sessions with discussions with you. Yeah. So today the modern buzzword is all about live online. We thought of having one face-to-face session in Hyderabad and live broadcast that. But the students requested, so this is more convenient. Face-to-face, 9 o'clock class starts means 8 o'clock we have to get ready, start in the home and come to the class. Whether we come to face-to-face or sit in the home, story yahi hota hai. So that is the reason you also sit happily in your home. We also will sit happily in our home and we can have home to home delivery of knowledge. Right? So that is the beautiness thanks to the YouTube and a good internet connectivity in the modern era. So doctor, this is the sacrum. This is the retrorectal space between the rectum and presacral fascia. And this is called the Waldeyer's fascia. This one is called Waldeyer's fascia. Then this is the levator muscle. Anococcygeal ligament. This is the rectum and this is the bladder. This is what you need to basically remember. So here you have the Waldeyer's fascia. So this alignment of the three-dimensional appearance is very important, doc. So your Denonville's fascia is between the rectum and the bladder. Bladder in front of it, rectum behind it. So fascia of Waldeyer, it attaches the lower part of the rectal ampulla to the sacrum. It is a condensation of the pelvic fascia, Waldeyer's, and it contains the superior rectal vessels and it contains the lymphatics. Similarly, pelvic floor, levator, lateral ligament of rectum, pelvic peritoneum, they are all the supports of the rectum. Is what you have to remember. So what is Denonville's fascia? Come on, who is going to punch the correct answer for this question, doctor? Come on, this question is for you to debate. What is Denonville's fascia? Denonville's fascia. Roshan is saying between prostate and rectum. Very good. Yes. Punch your answers, doc. Everybody, please join an interactive session. Be proactively keep answering questions, asking questions. That is the whole purpose of our interactive session. No, Abhishek. It is between prostate and rectum. Abhi padha hai na, doctor? Denonvillers fascia kahan hai? This is the bladder. This is the rectum. Between the two, you are having the fascia of Denonviller. Then this is the rectum. This is the sacrum. Between the ampulla of rectum and the sacrum, you are having valdae. You can't do a mistake, right? So between prostrate and rectum is Denonviller. And the rectum and sacral wall is valdae. These are all derivatives of the midgut, except ascending colon, appendix, jejunum. They're all the derivatives of the midgut. So, doctor, what is foregut? Esophagus to the first two parts of the duodenum you call foregut. Then third and fourth parts of duodenum to the first 2/3 of the transverse colon you call mesorectum, midgut. Then last third of the transverse colon to the upper part of the anal canal you call it as hindgut. That is what you have to emphatically remember. From the foregut, what arises? Esophagus, stomach, duodenum, liver, gallbladder, pancreas, spleen, and superior part of the pancreas. So, pancreas has one superior part, inferior part. Superior part arises from the foregut. And what is the blood supply of foregut, doc? Celiac trunk. Then midgut. Lower duodenum, jejunum, ileum, cecum, appendix, ascending colon, first 2/3 of the transverse colon, midgut. It is the branches of the superior mesenteric artery which will be supplying midgut. Hindgut is by the branches of the inferior mesenteric artery, all the remaining part of the gut. That is the last third of transverse colon, descending colon, rectum, upper part of the anal canal. They're all derived from the hindgut. Hostrations, where do you see them very prominently? We see them in the sigmoid colon. So, doctor, if you look at the anatomy of the large intestine, cecum is a blind sac. Cecum transverse diameter is very high. That is the reason anywhere be the obstruction. It can be in ascending colon, transverse colon or descending colon. Ultimately, the brunt is borne by the cecum. Because the wall pressure in the cecum, because of its high transverse diameter, the pressure in its wall is very high. And that leads to rupture of the cecum. So, cecum is a blind sac. And appendix is important because its wall has got lymph nodules. That's the reason appendix is also called abdominal tonsil, is the other name given. Then colon has ascending, transverse, descending, sigmoid. Right? Now, the circular muscle layer of the colon is complete, whereas longitudinal is incomplete and it is present like three bands. Three bands. What are they called? Tinea coli. And the contraction of this tinea, it will lead to formation of pouches, and they are called hostrae. And there are also small fat-filled pouches which are called epiploic appendages. That is the story of colon. Colonic mucosa has numerous straight tubular glands. They are called crypts. Colonic mucosa has goblet cells which are very predominant and they are absorptive. Whereas in case of small intestine, who is the counterpart of it? You have granular cells. Granular cells in small intestine are responsible for absorption. Goblet cells in the colon, large intestine, are the counterpart of granular cells in the small intestine. So that is what you should remember. Rectal continence is due to which muscle? Puborectalis. So, doc, you can remember this is the pubic symphysis, and here you have the coccyx. This is the rectal ampulla, and this fellow puborectalis, it will come and circle round the जैसे आप आपके प्यारे साथी को हाथ लगा के चलते ना, वैसे it will circle round the rectum and maintains the angle, anorectal angle. So that's the point you need to remember. What's the lymphatic drainage of the anal canal below dentate, above dentate? Favorite question of the examiner, doctor. It is superficial inguinal lymph nodes below the dentate. So typically if you look at the anus, above dentate, where you have anal valves, and below dentate. That's how you divide it. Above dentate, it is pleated, folded mucosa, whereas below dentate, the anus that you are able to see is smooth mucosa. Above dentate, you have 12 to 14 columns of Morgagni, which are absent in below dentate. Anal crypts are formed between these columns of Morgagni above dentate, whereas they are absent below dentate. Above dentate, most important point, cuboidal epithelium, cubes. You have cubes above dentate, cuboidal epithelium. Squamous epithelium is below the dentate. So this is the important thing. Invariably, examiner is going to ask you. So doctor, this is called pectinate line. You are able to see pectinate line. So arteries, what is the artery that supplies? Above the pectinate line, it is the inferior mesenteric artery. Where will the venous drainage above pectinate line go into portal venous system? And the lymphatics above pectinate line will go to internal iliac group of lymph nodes. And the nerves above pectinate, they are visceromotor, that is mixed sympathetic, parasympathetic and sensory innervation. Whereas below pectinate, it is somatic motor and sensory innervation. And below pectinate, lymphatic drainage goes to superficial inguinal group of lymph nodes. Above pectinate, it will go to internal iliac group of lymph nodes. That is what you need to remember. And below pectinate, it is the internal iliac artery which is supplying. Above pectinate, it is the inferior mesenteric artery which is supplying. That is the point you need to remember. So above pectinate is all visceral, below pectinate is all parietal, and pectinate is a dividing line. दिल लगा के अभ्यास किया ना इसको, definitely one MCQ is going to come from this. So the anal canal above the dentate is supplied by the terminal branches of the superior rectal artery, which is called hemorrhoidal artery, which is the terminal branch of the inferior mesenteric artery. So examiner is going to ask you in the tomorrow's exam that what is hemorrhoidal artery? It is superior rectal artery, terminal branches. And from where does superior rectal artery come? It comes from the terminal branch of the inferior mesenteric artery. And the lower anal canal is supplied by the middle rectal artery and inferior rectal artery. Now this is also very important. Why? Middle rectal artery is a branch of internal iliac artery. Inferior rectal artery is a branch of internal pudendal artery. They are the ones which are supplying the lower anal canal. Upper anal canal is by superior rectal artery, which is also called hemorrhoidal artery, which is the terminal branch of inferior mesenteric artery. So you have to be sharp, sure when you go to the exam tomorrow. Superior rectal artery is a branch of inferior mesenteric artery. Middle rectal artery is a branch of internal iliac artery. Inferior rectal artery is a branch of internal pudendal artery. Definitely examiner is going to ask whether it is FMGE, whether it is NEET PG, AIMS, PGI, JIPMER or any exam. Pectinate line is an important landmark. Why? Because it marks the divide in nerve supply. It marks the location of the change of epithelium. It represents a lymphatic divide, venous divide, arterial divide. That is the reason pectinate line is like India-Pakistan border. That's what you need to remember. Now comes the axilla. Anterior wall of the axilla is formed by pectoralis major. Now this calls you to remember, reproduce in tomorrow's exam, anterior wall, posterior wall, medial wall, lateral wall. Pectoralis major, pectoralis minor, clavipectoral fascia, anterior wall. Subscapularis teres major, latissimus dorsi, posterior wall of axilla, medial wall. The first four ribs, intercostal muscles, first four, and serratus anterior. Lateral wall, it is the bicipital groove, bicipital tendon along the humerus that constitutes the lateral wall. I am so happy to see 28 online students. Please invite your friends. Every Sunday, 45 Sundays, 360 hours of live online interactive session seamlessly. From Jan 26th, the Republic Day, till the November 30th, we have 45 Sundays. Right? So, we will do a very good revision and 2 cycles, 2 rounds will finish. First 21 weeks before June 30, we will finish 1 round of 19 subjects. Then next 24 Sundays, 1 more round of 19 subjects we finish so that we are ready for the exam. So December 1st to January 5th, every day we will have one full-scale grand test and discussion. Right? So that is the plan. So take an opportunity to give a call to 9000 868 356, our helpline, and subscribe to onlinembbs.com video library. You can tell also your juniors, classmates to join onlinembbs.com video library, where you have all these videos, everything archived into the onlinembbs.com along with 2 lakh PowerPoint slides of notes. Axillary artery and vein, typically infraclavicular part of the brachial plexus. Lymph nodes, the 5 group of lymph nodes, they are all the contents of axilla. L for long thoracic and intercostobranchial nerve, axillary fat, areolar tissue, these are all the contents of axilla. Which muscle does not form posterior wall? Teres major, subscapularis, latissimus dorsi, they are all posterior wall. What is present in posterior wall? Subscapular artery is in posterior wall. So along the lateral wall, the axillary vessels, brachial plexus, they are all running towards the apex of axilla. Along the posterior wall, subscapular vessels, they descend on the posterior wall, and along the medial wall there are no large vessels, but long thoracic nerve descends on the serratus anterior And the intercostobranchial nerve perforates the upper anterior wall, part of the posterior wall. That is what you need to remember. Now, doctor, clavipectoral fascia. What are the structures that pierce the boundaries of the clavipectoral fascia? Everything is examiner's favorite question. Clavipectoral fascia is not pierced by the median pectoral, but lateral pectoral, cephalic vein, thoracoacromial, they all pierce the clavipectoral fascia. So what is clavipectoral, doctor? The name itself says. Clavicle above to axillary fascia below. And the upper part of this will split. It encloses the subclavius muscle. And the lower part of this clavipectoral fascia splits. It encloses pectoralis minor. So it is like this, two splits, upper split, lower split. Upper split encloses subclavius underneath the clavicle, and the lower one encloses the pectoralis minor muscle is what you should remember. It will pull up the axillary fascia. And this upper part is also thickened. It's called costocoracoidal ligament, which is the thickening of the clavipectoral fascia. So what are the structures that pierce the clavipectoral fascia? Lateral pectoral nerve, cephalic vein, thoracoacromial vessels, and the lymphatics from the breast and the pectoral area. They all pierce the clavipectoral fascia. Level 3 nodes in the axilla. Level 3 nodes in axilla. They are formed by they are all supra-medial and above the pectoralis minor. So for you to classify the axillary lymph nodes into level 1, level 2, level 3, what is the benchmark, doctor? Pectoralis minor. So supra-medial and above the pectoralis minor, you have this level 3 nodes. So what is the anatomical classification of axillary lymph nodes? You can remember apical, A anterior, P posterior, I infraclavicular, C central, A apical, L lateral. These are all the components of the axillary group of lymph nodes. You call level 1 to all those lymph nodes which are inferior to the inferolateral border of the pectoralis minor. And what do you have in the level 1? Lateral, anterior, posterior. Lap. Lap group of lymph nodes are all there in the level 1. Level 1 is below the pectoralis minor. So you can see that this is the pectoralis minor, doctor. Below that is level 1. On that is level 2, above that is level 3 group of lymph nodes is what you have to remember. Level 2 nodes are posterior to the pectoralis minor and it includes the central nodes and some of the apical nodes. Level 3, they are beyond the superior border of the pectoralis minor and it has apical and infraclavicular. This is the clavicle. Infraclavicular group of lymph nodes are typically level 3 is what you should remember. Axillary sheath. What is it? It is a continuation of prevertebral fascia. Axillary sheath. So if you look at the axillary artery, the first part of it, along with axillary vein and brachial plexus, it is all enclosed in a sheath called axillary sheath. And this axillary sheath is a continuation of the prevertebral layer of the deep cervical fascia. Prevertebral layer of deep cervical fascia. So that is the point. Now comes Garma Garam topic. Coronary circulation. Third coronary artery. What is it, doc? Conus artery is also called third. You know, right, there is a left. राइट coronary, लेफ्ट coronary. थर्ड coronary क्या होता है? So this is the right coronary artery, right? This is the aorta, and here you have third coronary artery. So the first branch of the right coronary artery, sometimes it will arise separately from the aorta, anterior aortic sinus. Directly it can arise from that. That's called arteria coni arteriosi or conus artery. This is also called third coronary, but there is also a similar vessel which can also come from left coronary. So that is the reason third coronary say be better, you call it as a right conus artery is the name which is being given to it. So typically this is the aorta. You have an anterior aortic sinus. Aorta has sinuses from which coronaries arise. From that comes the right coronary artery. From the right coronary arises the right anterior conus. And the right coronary branches will extend posteriorly along the interatrial septum, and they go and supply the AV node. AV node. Then typically this is the conus. So this conus is supplied by the branch of the right coronary which is called as right anterior conus, third coronary artery. Then the left anterior descending artery is there, no doctor, which is arising from the left coronary, which is arising from the posterior aortic sinus. So this left anterior descending will give rise to left anterior conus artery. That and this right anterior conus together, they form an anastomosis, which is called annulus of Woussens, not nuisance. Woussens is what you need to remember. Now comes the venous drainage, favorite area. What are all the vessels, veins that drain into coronary sinus? Great cardiac, middle cardiac, left posterior ventricular, not anterior cardiac. Not anterior cardiac. Please remember, anterior cardiac vein does not drain into coronary sinus. अच्छा भैया, एक coronary sinus का जरा 3-dimensional align हो जाएंगे क्या? क्यों नहीं? Now, this is aortic arch. आप सबको परिचय है. This is the pulmonary trunk, superior vena cava, draining into the right atrium. Right? Now, this part is right ventricle, which is more anterior, and this is the left ventricle, which form the apex, and it is more apico-posterior. So here you have the major venous drainage happening into this tributary called as coronary sinus. So this is the great cardiac vein, and this is the middle cardiac vein, and this is called small cardiac vein, and small cardiac vein, middle cardiac vein, great cardiac vein. So this is, पहला आप three-dimensionally you need to get aligned. Very good. Irfan Sonu is saying, sir, anterior cardiac vein drains into the right atrium directly instead of draining into coronary sinus. देखो, by attending Dr. Murali Bharadwaj live online, anywhere, anytime, learn interactively sessions. हमको इरफान सोनू के जैसे क्लासमेट्स मिलेगा जो हमारे साथ पढ़ाई करेगा और a lot of value added points add करेगा. So that is the only advantage that you have, a great advantage. We are a huge cohort of seriously preparing candidates, students. Together, we have around 20,000 students on our WhatsApp group, various WhatsApp groups. We exchange a lot of notes, MCQs, discussions, anxieties, worries, happinesses. Yes, we need to be part of a cohort until we get the seat. After you get the seat, you become a cohort of postgraduates, your batchmates, your seniors. After that, you become a consultant, you become a cohort of consultants. Pediatric Society of India, that particular branch, all pediatrician cohort में join हो जाते, नहीं तो cardiologist के cohort में join हो जाएगा. So life basically is spent like school time cohort, medical college time cohort, entrance preparation cohort, and after that PG classmates cohort, then your co-consultants cohort. Life is a social gathering in various phases, various stages together. Then the stress will be lesser. So that is the whole purpose of anyone joining coaching program or a mentoring session, to subscribe yourself to part of a cohort. So I like to tell you all guys, onlinembbs.com is the best cohort which will be your companion in everyday preparation, every Sunday preparation, inspiring you at every stage, and most affordable. Throwaway price. The program is available. Now, coronary sinus receives the great cardiac vein at its left end. Left end में great cardiac vein drains. And the small cardiac vein on its right end. And the left posterior ventricular vein, if you go behind the heart, posterior ventricular vein, left marginal vein, they also open into the coronary sinus. But the anterior cardiac veins, they directly empty into the right atrium, as rightly said by Irfan Sonu. So now let us look in the anatomy. There's one atrioventricular groove between the atrium and the ventricles. Interventricular groove between the right and left ventricles. Crux of the heart, SCA node, AV node, you have to be very sure, three-dimensionally. So you all know this is the superior vena cava. This is draining into the right atrium. And typically you have the right ventricle, which constitutes a major part of the anterior surface, and the left ventricle, obtuse margin. This is called anterior interventricular branch, which is the branch of the left coronary artery. And this is the pulmonary trunk, whose opening into the right ventricle is by forming an infundibulum. Here posteriorly, more posteriorly, you have the left atrium. So you have to be very sure on this anatomy. Then you have between the atria and the ventricles, you have a anteroventricular groove. It is also called coronary sulcus. Between the atria and the ventricles, you have atrioventricular groove. What is the other name given for it? Coronary sulcus. Then you have a posterior interventricular sulcus. In that, your posterior interventricular branch, which is the branch of right coronary, posterior interventricular branch is the branch of right coronary artery will be passing. Then the middle cardiac vein, small cardiac vein, and the great cardiac vein, they're all draining into the coronary sinus, which is the major venous drainage of the heart. So, कहाँ मिलता है आपको coronary sinus? Posterior surface of the heart, right? So that is the place. Heart के पीछे आपको दिखाएगा. And these pulmonary veins, the 4 pulmonary veins which are bringing good blood, they are ultimately draining into left atrium. That's what you should remember. Then this is called crux. What is crux? Crux is the meeting point between the posterior atrioventricular groove, posterior interventricular groove, and the interatrial groove. All the 3 meeting point is called crux. So this is the typical location of the SCA node, and this is the right bundle branch, and these are the anterior papillary muscles, right ventricle, inferior vena cava, pulmonary trunk, aorta, superior vena cava, and how the superior vena cava is draining into the right atrium, and at that point of confluence you are having the SA node, the pacemaker of the heart. So what are the right coronary artery branches, left coronary artery branches? The right coronary artery will be giving rise to right conus artery, SCA nodal artery, right marginal artery, posterior interventricular artery, and finally a terminal branch of it. So these are all the right coronary artery. Left coronary artery, it gives anterior interventricular artery, which is also called left anterior descending artery. Circumflex artery, left marginal artery, and a diagonal branch, which is the branch of anterior interventricular artery. This left anterior descending artery will give rise to diagonal branches. So tomorrow you are going to become cardiologists. Your every day in and day out is all playing with this coronary arteries and the coronary circulation. So फटाफट और एक बार बोलो डॉक्टर, वो satisfaction आना है. राइट coronary artery branches क्या होता है? राइट conus, SCA nodal, right marginal, posterior interventricular, and a terminal branch. Left coronary branches, anterior interventricular artery and the diagonal arteries arising from that, and the circumflex artery and the left marginal artery. They're all the branches of the left coronary artery is what you should remember. So right coronary artery, it passes between the infundibulum of the right ventricle and the right auricle. Right? Infundibulum means pulmonary artery will be arising from the right ventricle. So that is the infundibulum. So between the infundibulum and the right atrium, the right coronary artery will be passing. It will be passing downwards in the anterior atrioventricular groove, and it reaches the inferior margin of the heart. It winds around it to the diaphragmatic surface, which is also supplying the inferior surface of the heart. इसलिए right coronary artery occlusion lead to inferior wall MI, and you get a ST segment elevation in lead 2, lead 3 and AVF is what you need to remember. So finally, where does it anastomose? It is the circumflex branch of the left coronary artery will ultimately be anastomosing with the right coronary's terminal branches. So, what are the branches of the right coronary artery? Once more, right conus artery, just before we studied that, third coronary it is also called, forming annulus of Wussen's. SCA nodal branch 60% of times from the right coronary. That is the reason any right coronary occlusion will lead to bradycardias. Similarly, anteratrial, anteroventricular, right marginal artery, which is the largest branch of the right coronary artery. Right marginal. Then posterior ventricular branches, posterior interventricular branch, 70% of times posterior interventricular branch arise from right coronary artery. If it does not arise from the right coronary artery, then you call, only when it arises from the right coronary artery, you call right dominance. Otherwise, it's called left dominance. If the posterior interventricular branch, from where does the posterior interventricular branch arise, is the definition of dominance of the coronary circulation. That is what you need to remember. Similarly, AV nodal artery also arises 80% of times from right coronary artery. So, doctor, these are the ventricular branches, AV nodal branch, and you can see the circumflex branch of the left coronary. Finally, it is the left circumflex branch which will anastomose with the right coronary artery behind the heart. So, right and left look like political parties, right party, left party, but ultimately everything anastomose. TV के पीछे निकलने के बाद all politicians are together. Only in the front of TV they will fight like they are going to kill each other, right? So left and right coronaries are also like that. Behind the heart everything anastomose. Left coronary arises from the aortic sinus, left aortic sinus. It passes behind the infundibulum of the right ventricle. Its length is about 1 centimeter. Tomorrow you are the stunt masters, no? As cardiologists, you should know the length also. And it bifurcates into left anterior descending and a circumflex. Left anterior descending will be giving rise to, it's a direct continuation of the left coronary artery. It extends beyond the apex and it will anastomose behind the heart with the posterior interventricular artery, which is the branch of the right coronary. So what are the branches of this left anterior descending? Left anterior descending artery is also called widow's artery. Widow's artery, because it is the most common cause for the atherosclerotic occlusion and the myocardial infarction. So left anterior descending artery branches are what? Diagonal arteries, left conus artery, septal branches, and anterior ventricular branch, they're all LAD branches. Then circumflex is the next second major blood branch of the left coronary. It runs in the anterior atrioventricular groove and posterior atrioventricular groove between the atria and the ventricles, and it terminates by anastomosing with the right coronary artery is what you should remember. Shriman, circumflex की branches क्या हैं? Atrial branches, ventricular branches, 40% of cases SCA nodal artery, instead of arising from the AV node, will be arising from the circumflex artery. Similarly, left marginal artery, posterior interventricular branch in about 10% of cases. Kujal's artery, Kujal's artery is a branch of circumflex. And AV nodal branch sometimes 10 to 20%. If the AV nodal is not arising from the right coronary, it will be arising from the circumflex artery is what you should remember. So you can remember this is the right coronary which will be giving rise to a synodal, conus branch, AV nodal, marginal, posterior interventricular, and is what it will be giving rise to. Then anterior interventricular is from the left coronary, and diagonal are the branches coming from the left coronary, and circumflex also is from the left coronary. So now comes an important question, doctor. Coronary dominance. It all depends on who gives rise to. Posterior interventricular branch decides the coronary dominance. Now, left coronary artery supplies greater part of myocardium, but 70% of cases posterior interventricular branch is a branch of right coronary. Hence we call, hey, this guy has right coronary dominance. That does not mean right coronary is dominantly supplying entire heart. Even in right coronary dominance, it is the left coronary only which is major supply of the entire heart. But it is a misnomer. It's a misnomer. Coronary dominance is decided by posterior interventricular branch is a branch of whether right coronary or from where is it coming from. It can even come from left coronary in 20% of cases, posterior interventricular branch. In 10% it is balanced. So that is a point you need to remember. Now, if the left dominance is there, why are you worried? If the left dominance is there, uska matlab posterior interventricular branch is arising from the left coronary artery. So any block in left coronary artery in a left dominant circulated guy will affect entire left ventricle, interventricular septum. Whereas if it is a right dominance guy, if there is any block of right coronary artery, at least it will spare 2/3 of the septum and the left ventricle. So that is the reason right coronary guys will have less damage than the left coronary guys whenever MI is there. So what is meant by dominance, doctor? From which coronary, whether it is right or left, from which coronary the posterior interventricular branch is arising is a determinant of the dominance, is what you need to remember. So in summary, right coronary artery, what does it supply? Right atrium, left atrium's anterior part, right ventricle except a small strip along the anterior interventricular groove, diaphragmatic surface of the right ventricle, posterior 1/3 of the interventricular septum, SA node, AV node, most of the conducting system of the heart, except the left bundle branch, everything else is right coronary. Whereas left coronary, posterior part of the left atrium, anterior and lateral walls of the left ventricle, anterior 2/3 of the IV septum, and the left bundle branch, and in 30% of cases, SA and AV nodes is what you should remember. So, anatomically, coronary arteries are not end arteries. There is a lot of anastomosis that occur, normally only. So between right coronary, left coronary, near crux of the heart, you get anastomosis, and their interventricular branches, posterior interventricular branch of the right coronary and anterior interventricular branch of the left coronary, typically in the septum, there is anastomosis. And also at the apex, there is a lot of anastomosis, is what you need to remember. Now, what are the various variations that can happen in the coronaries? Left coronary artery can arise from pulmonary trunk, sometimes, that lead to cyanosis. Left coronary artery can arise from the right aortic sinus, and that can become compressed between pulmonary trunk and aorta whenever you are doing a strenuous exercise, and that can lead to sudden cardiac death. So sudden cardiac death when exercising individual, strenuously exercising individual, can be because left coronary artery arising from right aortic sinus instead of left. It can get compressed between pulmonary trunk and aorta. Posterior interventricular artery instead of arising from the right coronary artery can arise from circumflex artery. That's called left dominance. Similarly, SA nodal artery instead of arising from right coronary, 40% of cases can from circumflex. AV nodal artery instead of coming from right coronary, in 20% of cases can come from circumflex. These are the important anomalies that you need to remember. So, posterior interventricular artery, suppose instead of arising from the right coronary, if it is arising from the left coronary's circumflex branch, then you call this as what? Left dominance is what you should remember. Right? So once more, coronary sinus, great cardiac vein, small cardiac vein which is draining, and posterior vein of left ventricle, middle cardiac vein, they're all draining into coronary. But you can see anterocardiac veins are directly draining into the right atrium. So that is a point. So what drains directly into right atrium? Venae cordis minimi, anterocardiac vein, sometimes right marginal vein also, they drain directly into right atrium. And what is coronary sinus? Coronary sinus is nothing but the dilatation of the great cardiac veins. Dilatation is coronary sinus. And coronary sinus opens into the right atrium. Mahipal is asking, sir, please repeat the anomaly slide. Very easy, doctor, very easy. Very easy. Yeah, anomaly slide. Am I right, Mahipal? Jara dil laga ke suno. Left coronary artery, instead of arising from the aorta, can arise from pulmonary trunk, and that can lead to cyanosis, because the right side to left side kalushit ho jayega, pollution ho jayega, if it arises from pulmonary trunk instead of from aorta. The person develops cyanosis. Left coronary artery arises from the right aortic sinus instead of from the left aortic sinus. Aorta may, from where the coronary arteries are arising, there is a sinus, right? So left coronary artery arises from the right aortic sinus anomalously, and it can become compressed between pulmonary trunk and aorta when you are strenuously exercising, and the person can die in the gym. Posterior interventricular artery, instead of arising from the right coronary, it can arise from the circumflex artery, is what you need to remember. Then SA nodal artery, 40% of cases arise from circumflex instead of from the right coronary. AV nodal in 20% instead of arising from right coronary, arise from the circumflex artery. डॉक्टर पटेल, समझ में आ गए ना? बढ़िया. अच्छा, वैभव पूछ रहे हैं, सर वेयर कोनस एनास्टोमोसिस occur? Typically at the cone, right? So conal anastomosis typically where the right and the left are merging from anterior towards posterior, the conal anastomosis. Now doctor, once more, great cardiac vein terminates in coronary sinus, middle cardiac vein terminates in coronary sinus, small cardiac vein Typically, it may open directly into right atrium. Oblique vein of left atrium, it's also called Marshall's vein. Marshall's vein. It runs along the posterior surface of the left atrium and drains into left end of coronary sinus. Then posterior vein of left ventricle, it runs along the diaphragmatic surface of left ventricle and it ends in middle of coronary sinus. And right marginal vein accompanies marginal artery and drains into small cardiac vein or directly into coronary sinus. So this is called oblique vein of left atrium. Left atrium, which is also called the Marshall's vein, vein of Marshall, is what you should remember. So what drains directly into right atrium? Anterior cardiac vein, small cardiac vein and Thebesian veins. They directly drain into right atrium. Everything else is a game. I took so much time so that this is such an important topic. Understand karna hai. Got to understand for the tomorrow's exam. Tomorrow some of you are going to become top cardiologists, right? So you'll remember me that I was there with you on this Sunday in your journey to make you understand, right? So great cardiac vein, where does it lie? Great cardiac vein is in the anterior interventricular groove. Anterior interventricular groove, great cardiac vein. And its dilated part is called coronary sinus. Anterior cardiac vein drains into directly right atrium. Left coronary artery supplies left atrium, left ventricle, anterior 2/3 of the interventricular septum is what you need to remember. Now comes the next topic, CSF. Maximum amount of CSF, where do you find it, Doc? We find it in subarachnoid space. So total CSF 150 ml, 125 intracranial, remaining 25 typically it is in ventricles. Inside the ventricles, almost all it is there in the lateral ventricles. And out of this 125, 25 ml is in ventricles. 100 ml is located in the cranial subarachnoid space. And what is the rate of CSF production, doctor? These are all single liner MCQs. 0.35 to 0.4 ml per minute. So every 5 to 6 hours, 50% of total volume of CSF become replaced. McGinty's foramen drains CSF from. It drains CSF from the fourth ventricle. So you should remember foramen of Luschka and McGinty, right? And these are the lateral ventricles. And this is the third ventricle. And that is draining into the fourth ventricle, right? Now, junction of the anterior horn and the lateral ventricle, what do you call it as? You call it as a trigone of lateral ventricle. If you look at the lateral ventricular structure, doc, there is a body, inferior horn, then there's a cerebral aqueduct, central canal, posterior horn, fourth ventricle. So you are having body, inferior horn, superior horn for the lateral ventricles. So the lateral ventricles connect to the third ventricle through the interventricular foramen of Monroe. Floor of fourth ventricle. This is a short answer question in MBBS exams and FMGE, USMLE, everywhere examiner is keen on this important question. It is formed by the posterior surface of pons, sulcus limitans and posterior surface of medulla. So it is also called rhomboid fossa of fourth ventricle. So you have the posterior surface of the pons, and you have a medial sulcus which divides the floor into symmetrical halves. There is a medial eminence, and here you have the sulcus limitans, a facial colliculus, and the cranial half of the medulla, and this is called stria medullaris, and this is a hypoglossal triangle, vagal triangle. So these are all the posterior view of the fourth ventricle. This is the posterior view of the fourth ventricle. It is also called floor of the fourth ventricle. So what is the rate of formation of the CSF per day? 500 ml, half liter. In the newborn, the total CSF production can be as little as 25 ml per day, and this will become 500 ml per day, half liter in a healthy adult. Now comes the favorite topic, epithelium types. Stratified cuboidal epithelium. Where do you see duct? Sweat gland ducts. Stratified cuboidal epithelium. Now this is called simple columnar epithelium, columns. Where do you find? Easy mnemonic is simple columnar, is typically stomach, intestine, respiratory tract, uterine tubes, fallopian tubes, auditory tubes, efferents of testis, brain in ventricles, and gallbladder. Simple columnar epithelium. Now these are the sweat glands and their ducts. So stratified cuboidal epithelium, two layers are there, right? So it is found in the ducts of the sweat glands, mammary glands, and salivary glands. Stratified cuboidal epithelium is seen in typically ovarian follicles. Epithelium of the ovarian follicles is stratified cuboidal, while that of the ovaries is simple cuboidal, is what you should remember. Which is not a connective tissue. Blood, bone, cartilage, they are all parts of connective tissue. Trachea is lined by pseudo-stratified columnar epithelium. This is how a pseudo-stratified columnar epithelium with the cilia looks like. Which is the epithelium lining the lingual surface of epiglottis. Stratified squamous epithelium. The entire lingual surface of the apical part of the laryngeal surface. Larynx is there, no doctor. It is covered with stratified squamous. The base of epiglottis on the laryngeal surface, it is a transition into ciliated pseudo-stratified columnar. So you are having in the larynx vocal cords, glottis. Above that is supraglottis, below that infraglottis, and the epiglottis is hanging and protecting the larynx from the gut secretions to flow from. So this epiglottis base on the laryngeal surface, the epithelium is ciliated pseudostratified columnar, because larynx become trachea. So ये ससुराल है. ससुराल में ससुराल वाले की epithelium होना है, that is ciliated pseudostratified columnar. Whereas the lingual surface is typically stratified squamous. Oral is mica. माइके वालों का epithelium होता है stratified squamous. That is the one which is there along the lingual surface. What is the epithelial lining of vagina? Stratified squamous, non-keratinized epithelium. So that brings us to the end of the first round of the game, doctor. So, as I told you, um, our pattern is like I'll give you 30 questions for you to answer. Go to the kitchen, pick up a kadak chai, come back, laze yourself, and solve the questions. After the quiz runs, I come back and 1 hour we will have discussion. Once more quiz, then 1 hour discussion. Once more quiz, 1 hour discussion. खेलते 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 हंसते हंसते हम 5 बजे तक खत्म करेंगे एक सब्जेक्ट को. 45 संडेज 2 राउंड्स ऑफ रिविजन करेंगे. कोई भी nobody can stop you from becoming the NEET PG topper. But you need to be willing to participate in the quiz, exercise your mind, and get ready for the next discussion. Will you promise me? Yes. So, doctor, let's take the second quiz. Second quiz. There are 30 questions. I'll put this on a slow mode. Slow mode and 30 seconds time ले लो. बराबर. Excellent. So, doctor, get ready to take the quiz. Answer the questions briskly. Another 15 minutes. I give you time for solving these 30 questions. I once more come back and we will have a discussion. Right? Until then, it is your show. Good afternoon, everyone, and welcome back to the today's session. Lohita, Rahman, Arju, and many more who are all online. Please drop a line to all your friends that the live class has restarted. I hope you all have answered very actively all the set of questions. Now let us make the great beginning. What are the boundaries of the Foramen of Winslow? One of the favorite questions of the examiner. Inferior vena cava, free border of the lesser omentum, second part of the duodenum, they're all the boundaries. So you should get an idea, three-dimensional idea, where is the Foramen of Winslow? Doc, this is the portal tract, hepatic artery, bile duct and portal vein. And this is lesser omentum, the stomach. This is called omental bursa. Here you have inferior vena cava, aorta. Then this is the spleen, and there is a splenorenal ligament, and the typical structures. So here you are passing the index finger through the omental foramen. Omental foramen. So this is the another view of the same story. You have the lesser omentum and the finger is inserted into the omental foramen, into the omental bursa. So now we are talking about what are the borders of this epiploic foramen. Anteriorly, what do you have? The free border of the lesser omentum. Free border of the lesser omentum. It is also the one which is connecting the liver with the duodenum, lesser omentum. So hepatoduodenal ligament is the other name which is being given for the lesser omentum. Liver and duodenum are connected. So this is the stomach, stomach become duodenum, duodenum and the liver are connected by the lesser omentum. Its free margin forms the anterior boundary of the epiploic foramen. Then if you look at this lesser omentum, it has two layers, and within these layers are common bile duct, hepatic artery and hepatic portal vein. So anteriorly the lesser omentum's free border is forming. Posteriorly to this epiploic foramen, that part of peritoneum which is overlying the IVC and aorta, the peritoneum covering the inferior vena cava forms posterior boundary. And superiorly, it is the caudate lobe, not the quadrate lobe. Caudate lobes, peritoneum which is covering the caudate lobe is the one which constitutes its superior boundary. Then inferiorly, the peritoneum which is covering the commencement of duodenum. Duodenum is here, right? So duodenum is typically inferior and the hepatic artery. Then left lateral is gastrosplenic ligament and splenorenal ligament. So these are the important borders of epiploic foramen. Three-dimensionally you need to imagine and reproduce in the tomorrow's exam. So superior border of the epiploic foramen is formed by caudate, not quadrate. Caudate lobe of liver. Posterior relation of epiploic foramen is by the peritoneum, which is overlying the inferior vena cava. So if this is anterior, this is posterior. Anterior is formed by the free border of lesser omentum. Posterior is inferior vena cava is passing. The peritoneum overlying that is there. That forms the posterior boundary of epiploic foramen. Now the various joint types. Sphenoid omer joint is which type of joint? It is shindylisis. It is a shindylisis. So this is how a plain suture, serrate suture, squamous suture, denticulate suture, and here the rostrum of sphenoid and ella of oma, between them the joint is called shindylisis. Shindylisis is a specialized type of suture where a rigid bone fits into the groove of a neighboring bone, like the ala of the vomer, which receives the rostrum of the sphenoid, is a shindylisis, is what you should remember. Incudomalleolar joint is formed. What type of joint? Saddle joint. So quickly, a look at the various types of joints, doctor. In saddle joint, what is happening? Saddle means you are sitting on a horse and riding, right? The concave surface of one bone will articulate with the convex surface of the other, and the best example is the carpo-metacarpal bone of the joint of the thumb. What are the other saddle joints, doc? First carpo-metacarpal, sternoclavicular, incudomalleolar, calcaneocuboid. There is a riding on the saddle. Similarly, there is a plain joint, saddle joint, hinge joint, pivot joint, ball and socket, ellipsoid joint. So that's how the various joints are. 1-2 comments about each of them. Plain joint. It is also called gliding joint. One move across the surface of the another. It allows sliding or gliding. Acromioclavicular joint. Acromioclavicular joint is an example of plain joint. Hinge. It is also called ginglymus. It allows the movement around one axis that pass transversely through the joint. So it permits flexion extension. Humero-ulnar joint is an example of hinge joint. Pivot joint, also called trochoid joint. It also allows movement along one axis that passes longitudinally along the shaft of the bone. Atlanto-axial joint. Then bicondylar joint formed by two convex surfaces, condyles, that articulate with the concave surface. Knee joint is a bicondylar joint. Condylar joint is also called ellipsoid joint. It will permit flexion, extension, abduction, adduction, and limited circumduction. And wrist joint is a condylar joint. Saddle joint, carpometacarpal joint of the thumb, first carpometacarpal, and sternoclavicular. Ball and socket is hip joint and glenohumeral. Glenohumeral is what you should remember. These are all fibrous joints. Skull suture, syndesmosis, gomphosis, they're all fibrous joints. So according to the structure, You define it as cartilaginous, fibrous and synovial. Cartilaginous, connected entirely by the cartilage, highly mobile. It allows more movement between the bones compared to fibrous joint. But synovial joint is most mobile. Fibrous is least mobile. Cartilaginous falls in the middle. Synchondrosis, symphysis, they are all cartilaginous joints. Synchondrosis, otherwise called synarthrosis, is a primary cartilaginous joint. So there will be two ossification centers in the developing bone that remain separated by a layer of the cartilage. वो होता है synchondrosis, primary cartilaginous. It will allow the growth of the bone eventually become completely ossified. Whereas symphysis is secondary cartilaginous. That is simply two separate fully ossified bones are connected by a cartilage. That's all. No further growth. It occurs in the midline. Pubic symphysis. Intervertebral disc. They are all symphysis is what you should remember. Fibrous. They are connected by dense connective tissue. They contain mainly collagen. Sutures, syndesmosis, gomphosis, they are all fibrous. Temporomandibular joint. Temporomandibular joint. It is a condylar joint. So, condyloid joint is between radius and scaphoid and lunate bones of the carpus. Radiocarpal joint is an example of condyloid joint. Superior radioulnar joint is a pivot joint. So, doctor, actually there are, if you go back to the onlinemmbbs.com video library, there is a more detailed video library on each of these topics. I am only taking few questions, few sample questions underneath each topic and doing a quick revision for you. Mainly to draw your attention to go back to the onlinemmbbs.com video library and do an extensive revision of entire anatomy, AIMS question bank, All India question bank, FMGE question bank. You need to do a review. You have all the notes topic wise in the form of PowerPoints available in the onlinemmbbs.com. फिर भी आपको वो motivation के लिए हम एक interactive session. That is the whole purpose. Now you got it? Liver. What is the basis of the division of the anatomical segments of the liver? It is the hepatic artery, portal vein, bile duct, not hepatic vein. Right? So that is the basis. So biliary, hepatic, arterial and portal venous supply of the liver will follow similar distribution defined by hepatic segments. So there are totally 8 segments. Segment 4 sometimes is divided to 4A and 4B according to Bismuth. The numbering is typically in a clockwise manner. Segment 1 is the caudate lobe is located posteriorly. It is not visible in the frontal view. So caudate lobe of the liver lies in segment 1. 1 hota hai caudate. Caudate lobe is what you should remember. Right? So what you can see is 2, 3, 4, 5, 6, 7, 8. So it is typically in a clockwise manner. Caudate lobe typically stays posteriorly. So you have the 5, 6, 7, 8 located in the right lobe. Whereas 2, 3, 4A, 4B are located in the left lobe and caudate is posteriorly located. So that is what you need to remember. So the caudate lobe, which is called posterior hepatic segment, it is also called Spigelian lobe. It is located in the posterior superior surface of the liver is what you should remember. How does ligamentum teres, from where does it develop from? So you should remember it develops from umbilical vein. Umbilical vein. So this is the right lobe, doctor. This is the left lobe. This is the coronary ligament. And this is the falciform ligament. And this is the round ligament. Round ligament का दूसरा नाम होता है ligamentum teres, is what you should remember. The round ligament of the liver is a degenerative string of tissue that exists in the free edge of the falciform ligament. Falciform ligament's free edge. And it is a fetal left umbilical vein. Fetal left umbilical veins remnant is the round ligament of the liver, which is also called ligamentum teres, is what you should remember. So embryologically, if you take, there is a sinus venosus, this is the cardinal vein, this is the left vitelline vein, this is the umbilical vein. Now, the hepatic sinusoids develop, and ultimately, what is the structure? What is the structure? You have the hepatic veins, this is the portal vein, superior mesenteric and splenic vein together form the portal vein, and this is the hepatic vein where all the sinusoids ultimately drain into inferior vena cava. So, hepatic vein is basically formed from right vitelline vein. Then, in the embryonic life, you have the right hepatocardiac channel. Hepatocardiac channel that become the hepatic portion of IVC. The right-sided umbilical vein will regress. In the left umbilical vein, proximal part also will regress, but the distal part of the left umbilical vein will remain as the ligamentum teres. And the ductus venosus in the embryonic life will typically become ligamentum venosum. So ligamentum teres is round ligament of liver and left umbilical vein, whereas ligamentum venosum is ductus venosus. Ductus venosus. That's what you should remember. Many times examiner will try to ask a favorite MCQ only on this important issue. Kupffer cells are found in liver. Now comes the orbit. Orbital septum. How is it formed? It is the palpebral ligament. So this is the aponeurosis of the levator palpebrae superioris. This is the lateral palpebral commissure, lateral palpebral ligament, and this is the orbital septum. This is the superior tarsus, inferior tarsus. This is the medial palpebral commissure and the medial palpebral ligament, and here you are having the lacrimal sac. So, orbital septum extends from the orbital rims to the eyelids. Orbit ka rim रहता है ना, bony orbit का, वहाँ से it will extend to the lids. It forms the fibrous portion of our eyelids is formed by it. Now, what is the maximum contribution to the floor of the orbit? It is the maxillary bone, which is the major contributor. So, orbital plate of maxilla, it is thin. Blowout fracture can occur and the orbital contents can herniate into maxillary sinus, which is called as the fat pad. It's like an oil drop. It will be drooping down into the maxillary sinus. Similarly, orbital process of palatine bone, orbital surface of zygomatic bone, orbital plate of maxilla, these are the things that form the floor of the orbit. It is thin and blowout fracture can occur. That is what you should remember. So, orbital surface of the maxilla is a smooth triangular bony portion which form the major component of the floor of the orbit is what you should remember. apex of the orbit. Basically, all these extraocular muscles form like a cone. So, which is not attached to the apex? Inferior oblique is not attached. Superior oblique, superior rectus, inferior rectus, they are all attached to the apex. So, this is superior oblique, superior rectus, annulus of Jim, lateral rectus, medial rectus, inferior rectus. They are all attached to the apex. But this one is the inferior oblique. It does not attach to the apex, is what you should understand. Which bone do not contribute to the medial wall of the orbit? Dekha, kitna examiner sincerely asks questions from very standard topics. Ethmoid, lacrimal, frontal, they all form the medial wall of the orbit. Right? So, this is frontal, this is ethmoid, this is lacrimal, medial wall of the orbit. Maxillary forms the floor, zygomatic forms the floor, is what you should remember. The roof is formed by the sphenoid and frontal. Posterior aspect of the lateral wall is formed by the zygomatic and sphenoid. Floor is formed by maxillary, zygomatic and palatine. And medial wall is formed by the ethmoid, lacrimal and frontal. So, even if you are going for anatomy, university exam, orbit walls, what forms the walls of the orbit is a favorite question. A fully adducted eye, if you want to elevate, you require inferior oblique. So you should be very sure what are the primary actions. Medial lateral rectus, easy to remember, adduction, abduction. Superior rectus is elevation, which is maximal in abduction. Inferior rectus, depression, maximal in abduction. Superior oblique lead to depression, maximal in adduction. Inferior oblique is elevation, maximal in adduction. So this is what you have to be 100% sure, doctor. If you adduct, then obliques are elevators and depressors. If you abduct, then the recti, superior and inferior recti are the elevators and depressors. Simple. Okay? Now, spermatogenesis. Secondary spermatocyte. What is composition, chromosomal composition? It is haploid. So you should know, like the Queen Elizabeth and her father, her grandfather, great-grandfather, like that you should know what is the lineage of our spermatogenesis. 2N is spermatogonium. It undergoes mitosis to produce 2 sperms, each containing 2N. Then it undergoes meiosis 1 to produce secondary spermatocyte, and that is the first time where it became haploid. It undergoes meiosis 2 to form the spermatids. They undergo differentiation to form sperms. So spermatogonium, secondary spermatocyte, spermatid and sperm, and secondary spermatocyte is the first time where it became haploid, is what you should remember. Which will not undergo division? Spermatids. Spermatids only differentiate, they don't undergo division. Whereas spermatogonium, secondary spermatocyte, they undergo division. During ejaculation, how are the sperms released and they do swimming? So you should remember, they are released from epididymis. So what is the journey of the sperm? So basically, doctor, these are the seminiferous tubules. They have lobules, septum, tunica vaginalis, tunica albuginea, tunica vaginalis, right? Like meninges. Then this is called tubulus rectus, that become rete testis. These are the efferent ductules. Efferent ductules. And they all merge. And this is the body of epididymis, tail of epididymis. And this is the head of the epididymis. And this is vas deferens. Vas deferens is what you need to remember. Okay, so the journey starts in seminiferous tubules. It goes to straight tubule, to rete testis, to efferent tubule, to epididymis, to vas deferens, to ejaculatory ducts, to urethra is what you need to remember. That's how the sperms do the journey. Mitochondria of the sperms, where do you see? We see it in the middle piece. So there is a tail, there is a middle piece, there is a whatever, beautiful head, nucleus, acrosome, necklace, everything is there for sperm. Sperm is beautifully ready to attract the egg to accept it. So the mitochondria is typically there in the middle piece. What are the supporting cells of the testis? They are the Sertoli cells. So this is the spermatid, spermatozoa, primary spermatocytes, grandpa. Then spermatogonia, pa. Spermatid, son. Spermatozoa, grandson. So there are a lot of supporting cells which are called Sertoli cells, is what you should remember. So next, triangles, quadrangles is the next favorite topic. Between scalenus anterior, longus colli, the triangular interval, what are the structures that pass? Sympathetic trunk, thoracic duct, inferior cervical ganglion, they all pass between scalenus anterior, longus colli. So doctor, you need to get a little three-dimensional idea about the various structures in our neck. This is the longus capitis, doctor. This is the rectus capitis. Then this is the middle scalene, posterior scalene, anterior scalene. And this is rectus capitis anterior, whereas this is called rectus capitis lateralis. Then this is called longus colli. Longus colli. So this is the typical structure. So before vertebrae you have anterior vertebral muscles. Longus colli, longus capitis, rectus capitis anterior, rectus capitis lateralis. So between scalenus anterior, this is the anterior scalene. So between scalenus anterior and the longus colli, so this is the longus colli. Scalenus anterior and the longus colli. In the triangle, common carotid artery will be passing. So what is that called as? Longus colli is attaching to the vertebra. And anterior scalene is the muscle which is going towards clavicle. So between the two, in the triangle, the common carotid artery will be passing. So the longus colli, scalenus anterior, transverse process of the sixth cervical vertebra. sixth cervical vertebra, transverse process. They form the triangle, scaleniovertebral triangle. What does it contain? It contains first part of subclavian, sympathetic chain, vertebral artery, and on the left side it will be containing even thoracic duct on the left side. So these are the structures which are passing through scaleniovertebral triangle. Now, doctor, Kellogg's triangle. What are the structures which are passing through the Kellogg's triangle? Kellogg's triangle. Cystic artery, right hepatic artery, lymph node of Lund. They're all passing through the Kellogg's triangle. So this is the cystic duct, doctor. Common hepatic duct. Liver inferior surface. Here you have the Kellogg's triangle. It is also called hepatobiliary. This is a common bile duct, right? So hepatobiliary triangle. So inferior surface of the liver, common hepatic duct medially, cystic duct inferiorly form the Kellogg's triangle. So you can see this is the cystic artery and anterior cystic artery. Ultimately cystic is all supplying. Cystic is all supplying the gallbladder. So this is a cystic duct and common hepatic duct, inferior surface of the liver, Kellogg's triangle, and you can see beautifully the cystic artery which is passing through it. So the cystic artery, then right hepatic artery. You know, this is the left hepatic artery, this is the right hepatic artery. Even right hepatic artery is passing through the Kellogg's triangle. And there is a lymph node which is called a lymph node of Lund, is also the component of the Kellogg's triangle. Now, doctor, what are the contents of the adductor canal? Adductor canal has femoral artery, nerve vastus medialis, and saphenous nerve. So you all answered the questions, right? So before attending discussion, if you answer this like a quiz or a test, it will be very interesting, right? Discussion looks more appealing, interesting, and you will not forget. If you do mistake and then listen a class, you will never forget. If you do right and listen the class, you get some extra points. So that is how we need to use a combination of a pre-test followed by discussion. Deal? Now, adductor canal. So this is the vastus medialis, sartorius. You can see the femoral artery, saphenous nerve passing to the adductor canal. Adductor canal is also called subsartorial canal. It is underneath the sartorius muscle. इसी का दूसरा नाम है Hunter's canal. Typically it extends from the apex of the femoral triangle, to the opening of the adductor magnus. That is the adductor canal. So anterior and lateral is this vastus medialis muscle. How is this adductor canal as a tunnel? Guha hai. So typically anterior, posterior, lateral, medial. Anterolaterally vastus medialis. Posteriorly you have adductor magnus, adductor longus. And the roof and medial part is by the sartorius. So you should be very sure on these boundaries of the adductor canal. A short answer question in the MBBS first year exam. So what are the contents? It contains femoral artery, femoral vein, femoral nerve branches. specifically saphenous nerve and the nerve to vastus medialis. It has three foramina, superior, anterior, inferior, and it is through the superior foramen through which the femoral artery, femoral vein, and saphenous nerve will enter into the adductor canal, is what you should remember. And the saphenous nerve and artery, they exit through the anterior foramen. Finally, femoral artery and vein exit to the inferior foramen, which is a gap in the adductor magnus muscle. So this is all the anatomy of the adductor canal. One of the favorite questions of the examiner. Now, doctor, cubital fossa. The beautiness of anatomy is it's a very fixed subject, very fixed, like a fixed deposit. फिक्स्ड डिपॉजिट डालने के लिए ही आप कोशिश करना पड़ेगा. एक बार डाल दिए तो फिक्स्ड डिपॉजिट रिमेन्स फॉर एवर एंड इट कीप मल्टीप्लाइंग. Anatomy also, first round, just to align your mind into all these structures, थोड़ा time लगता. But once you spent around 20-25 hours quality time with Dr. Murli Bharadwaj, I'm only revising you in this 8 hours on Sunday. But there is about another 50 to 60 hours of anatomy, PowerPoints, everything in the online mbbs.com video library. My hope is, after finishing this, you are inspired thoroughly that you go back and do a quick revision on the online mbbs.com video library. Okay, now, cubital fossa. What are the boundaries? Laterally, it is the brachioradialis. So you have a prunita arteries, brachioradialis, and the imaginary line which is joining the two. Most medial, a nerve, middle artery, and most lateral will be a tendon. Nat are the structures medial to lateral in cubital fossa. So this is the biceps brachii and its tendon. So tendon is most lateral structure. Then you have the median nerve, brachial artery. So nerve is most medial, artery in the middle, and tendon of the biceps brachii is most lateral, is what you should remember. Right now, ureter is our next question, next topic. Ureter, in ureteric tunnel, where is it located? It is inferior to uterine artery, ureter. So let us once more get a realignment of all these structures, doctor. One of the favorite questions. This is the uterine artery, this is the ureter. Ureter is inferior to the uterine artery. That means uterine artery is crossing the ureter. Right? And in the process of clamping this, gynecologists can end up in injuring the ureter. This is the lateral cervical ligament connecting the cervix to the lateral structures in the pelvis. It is also called cardinal ligament. Then uterosacral is connecting the cervix with the uterus with the sacrum posteriorly. And this is the broad ligament. Barabar? So a three-dimensional soch vichar banna chahiye. So the cardinal ligament, this lateral cervical ligament is called cardinal ligament. इसको तरह की नाम है. That is the whole confusion. Cardinal ligament को भी बोलते हैं Mechondrops, lateral cervical, transverse cervical. Everything is cardinal only, and it contains uterine artery and uterine vein. And in hysterectomy, it is of a great significance because it is in a very close proximity to the ureter. And It can get damaged if you are trying to ligate this cardinal ligament, the lateral cervical ligament. That is what you need to. The whole MD gynecology obstetrics is all about ligating the cardinal ligament without injuring the ureter. Right? Now, doctor, what are the normal constrictions of the ureter? At pelvic ureteric junction, at pelvic brim, and where it is entering into bladder. So, at the pelvic ureteric junction, where there is origin, at the pelvic brim and vesico-ureteric junction, there are the three locations where ureter is having the constriction. Now, what are the relations of left ureter, right ureter, left kidney, right kidney? You have to be 100% sure for the tomorrow's exam, doctor. So, left ureter is related to quadratus lumborum, psoas major, left gonadal vessels. They are all typically relations to left ureter. Now, let us talk. Right ureter. ओके भैया, राइट में लिवर है, लिवर के नीचे गॉल ब्लैडर है, इधर किडनी है, इधर से यूरेटर निकल रहा है. अच्छा, अभी बोलो ये राइट यूरेटर का क्या क्या रिलेशंस होता है? द डिओडिनम, द टर्मिनल पार्ट ऑफ इलियम, द राइट कोलिक, इलियोकोलिक वेसल्स. Imagine everything on the right side. Right testicular ovarian vessels, root of mesentery of small intestine, right ureter. Posterior relations, what are they? To the right ureter. The right psoas is behind right ureter and it separates it from the lumbar transverse process. And the bifurcation of the right common iliac artery into external iliac, the right common iliac, aorta divides into common iliacs divide into external and internal iliacs. So the bifurcation of the right common iliac is also posterior relation to the right ureter. Then how about the left ureter? Left ureter anteriorly, you have the sigmoid colon, sigmoid mesocolon. So typically ascending colon, transverse colon, descending colon becomes sigmoid colon and rectum, no? So the sigmoid colon is the anterior relationship of the left ureter. And the left colic vessels, obviously colon should be supplied by left colic vessels and they are anterior to left ureter. The left testicular, left ovarian, all gonadal veins, vessels are anterior. And the inferior mesenteric vein, very important, inferior mesenteric vein, it is medial to the left ureter. Then posteriorly what do you have? Left psoas separating it from the lumbar transverse process, and the bifurcation of the left common iliac artery is posterior to the left ureter. So some of you are going to be finest urologists of India. So that time, every day in and day out, these relations make a lot of difference. So what are the anterior to the left ureter, doctor? Once more, और एक मर्तबे रिविजन करेंगे. लेफ्ट यूरेटर का एंटीरियर में क्या होता है? डिसेंडिंग पार्ट ऑफ द डिओडिनम, राइट कोलिक वेसल्स, इलियोकोलिक वेसल्स, टेस्टिकुलर वेसल्स एंड terminal part of ileum. What is right to the left ureter? Cecum and vermiform appendix. Anterior is left colic vessels, testicular vessels and duodenojejunal flexure. Now comes the relationships of the kidney. So the right suprarenal gland, liver, they are talking about the anterelation of kidney. Descending part of the duodenum, right colic flexure, small intestine, they are all anterior to kidney. Then what is anterior to the left kidney? Left suprarenal, stomach, spleen, pancreas, left colic flexure and descending colon, and jejunum, they're all anterior. So right kidney के front में क्या है? Suprarenal, liver, duodenum, right colic flexure and ileum. Left kidney, suprarenal, stomach, spleen, splenic artery and pancreas. This is a very important VVIMP MCQ in the tomorrow's FMGE, NEET, PG, whichever exam you see. Then what is posterior? Kidney के पीछे क्या है? The diaphragm separates the kidney from the pleural cavity by 11th and 12th ribs. Psoas major is posterior and it is located medially. Quadratus lumborum, transverse abdominis laterally, subcostal iliohypogastric ilioinguinal descend obliquely behind the kidney. So once more, and relationship of ureter क्या होता है? Duodenum, terminal ileum, right gonadal vessels, right colic vessels, ileocolic on the right side. Left side, left gonadal, left colic and sigmoid colon and mesocolon. That is what you should remember. Now, one of the favorite MCQs of the examiner is, you should also know surface anatomy of kidney. So kidney is having a hilum. Barabar? So hilum is 3 finger breadth from the midline in the transpyloric plane. Transpyloric plane. And on the back, how do you identify kidney? You will look for T12 spine. So T12 to L3 spine, the kidney is extended. Kidney move about 1 inch in 2.5 centimeters with respiration. Kidney will be moving. The right kidney, liver है ना, liver के नीचे right kidney है ना. The right kidney, this liver will push the kidney down. So right kidney is 1 inch lower than the left because of the liver. That is what you should remember. How about ureter? Ureter anteriorly. How do you represent? A 0.5 centimeters from the midline. 5 centimeters from the midline at the level of L2, second lumbar vertebra, to a point of anterior iliac spine. It is located, and posteriorly it is from the spine of the L1 spine to the posterior inferior iliac spine. It is extended. So that is the story of ureter surface anatomy. So somehow you need to remember, reproduce in the tomorrow's exam. Ectopic ureters in males, where do they open? They commonly open into prostatic urethra. Ectopic ureters. So ectopic ureter usually opens into the neck of the bladder or the prostatic portion of the urethra. Urethra has got a membranous, prostatic, bulbar and penile urethra, no doctor? So typically it opens into the neck of the bladder or prostatic portion of urethra. Rarely it will open into ductus deferens, prostatic utricle or seminal vesicle. In case of the females, ectopic ureter opens into the bladder neck, urethra, vagina, vestibule of vagina, anywhere it can open into. What is the narrowest part of ureter, doctor? So ureter, while it is originating from the kidney, pelviureteric junction, one constriction. Other is at the level of the pelvic brim. Third is when it is entering into bladder. That is the narrowest part of the ureter, is what you should remember. Barabar? Now, doctor, yes. Are you ready for the next quiz? Next installment of questions के लिए ready है? Very good. But please answer the questions. By doing so, you are very active, vibrant, energetic, and part of the game. That is what is important, doctor. Anytime, if you want to be a winner, you should be part of the mission. You should not stand away from the mission and should be pushed by somebody to enter into that mission. No, it is your mission. You should be part of the mission. You should actively, vibrantly participate, and that gives you the required willpower to win the battle. Right? Now, doctor, let us take up the next bout, anatomy, third quiz followed by discussion. Then we will go for lunch. So there are 29 questions, doctor. I'll try to put it little faster. Every 20 seconds you should answer. We will try to set it up like that. Now, doctor, punch your answers. I will take a 10-minute break. You also pick up a cup of tea and then solve the questions, and then we will join for the discussion. Good afternoon, everybody, and welcome back to the Mission Anatomy. So, please tell your classmates. And friends that class restarted. Yes, doctor. Now, the next favorite topic of the examiner is cerebellum. What are the most lateral deep cerebellar nuclei? Dentate nucleus. So you should remember, cerebellum has a vermis, hemispheres, and it has nuclei. So this is most lateral is, you are able to see this fastigial nucleus, then emboliform nucleus. This yellow one is globose nuclei, and most medial of all, you are having typically the dentate. So the most lateral is dentate, the most medial is fastigial, and after fastigial you have globose ke baad emboliform, then most lateral is dentate, is what you need to remember. Now doctor, one easy way to remember, don't eat greasy food. D is dentate, most lateral, then emboliform, then globose, then fastigial. Fastigial is most medial. What are the cells that are present in cerebellum? Cerebellum is having Purkinje cells, then dentate nucleus, fastigial nucleus, but pyramidal cells are there in the cerebral cortex. So if you look at the various layers of cerebellum, there is a molecular layer, Purkinje cell layer, and granule cell layer. In the granule cell layer, you are having the climbing fibers. These are the Purkinje cell, this is the granule cell, the mossy fibers, etc., etc. The histology of cerebellum is a favorite topic of the examiner. So what are the various cells in the cerebellum, doctor? Purkinje, granule cells, mossy cells, and climbing fibers. And what are the interneurons? Golgi cells, Lugaro cells, stellate cells, basket cells. They are the various interneurons. Through inferior cerebellar peduncle, what will be passing? So you should know that we have a brainstem. What do you have in brainstem, doc? Brainstem basically has on the topmost part you are having midbrain. Then you have pons, finally medulla. These three are connected with the cerebellum with three cerebellar peduncles. Superior cerebellar peduncle connects midbrain, middle cerebellar peduncle connects pons, inferior cerebellar peduncle connects with medulla. So ultimate all information coming from spinal cord will reach the inferior cerebella, the medulla. Through the inferior cerebellar peduncle goes to the cerebellum. Similarly, all the pontine information also goes to the cerebellum. And from cerebellum, communication to the brain, cerebral cortex, how does it happen? From cerebellum, it goes through supracerebellar peduncle to reach the midbrain. From midbrain, it will go to red nucleus, to thalamus. From thalamus, it will go to cerebral cortex. That is the reason it is called dentato, rubro, thalamo, cerebral tract. That is the name which is being given to it. So, what passes through the inferior cerebellar peduncle? Obviously, vestibulocerebellar tract, olivocerebellar tract, dorsal spinocerebellar tract. There is one inferior olivary nucleus. Inferior olivary nucleus in the medulla. It is the one which will send the information to cerebellum, olivocerebellar tract. Then similarly, from the spinal cord comes the dorsal spinocerebellar tract. And from your vestibular nuclei about the balance, information will reach the pontomedullary junction, and through the inferior cerebellar peduncle, it will go to the cerebellum. That is how our semicircular canals perceive the saccules, utricles, everything, get the information about the balance equilibrium. They will pass it to the vestibular nucleus, which is located in the pontomedullary junction. And from there, through the inferior cerebellar peduncle, it will be going and reaching the cerebellum. That's what you should remember. So, superior cerebellar peduncle to midbrain, middle is to pons, inferior to medulla, you should not forget. Through inferior cerebellar peduncle, what fiber systems pass? Dorsal spinocerebellar tract passes through inferior cerebellar peduncle. Cuneo-cerebellar tract from the accessory cuneate nuclei. Olivocerebellar tract from the inferior olivary nucleus. Reticulocerebellar tract, typically in the midbrain, you are having reticular information, reticular formation. So from this reticular formation, the fibers come down, reticular nuclei, they will come down to the medulla. And through the inferior cerebellar peduncle, information will then be passed on to the cerebellum. So cerebellum will be knowing whether this guy is awake or not. So reticulocerebellar tract. Similarly, vestibulocerebellar tract, that also passes through. Inferior cerebellar peduncle is what you need to remember. Then arcuatocerebellar tract, from arcuate nuclei to medulla. Trigeminocerebellar tract, from the spinal and main spinal nucleus of trigeminals, main sensory nucleus of trigeminal, even they pass the information to cerebellum through the inferior cerebellar peduncle. Then what enters through middle cerebellar peduncle? Middle cerebellar peduncle connects the cerebellum with the pons. So pontocerebellar fibers from the pontine nuclei. Similarly, there are raphe nuclei, which are serotonergic fibers. They also pass through the middle cerebellar peduncle. Then what are the fibers passing through superior cerebellar peduncle? Superior cerebellar peduncle. Akshay Mishra is saying, Happy Republic Day. Definitely, January 26th is a very auspicious day for us to make the beginning for 2021 season, NEET PG 2021. Next 45 Sundays, every Sunday, 8 hours. Our live online interactive session should inspire you to complete one subject every Sunday. And we have 2 cycles of revision, and typically you are very well equipped. And my intention is basically to see that at the end of this 8 hours of interactive session, you are quite inspired about a lot of topics. And you go back to the onlinemmbbs.com video library, where you have a complete encyclopedic spectrum of the entire subject, and that you will be able to do the revision. So please take every opportunity to call our helpline 9000 868 356 and subscribe to the online mbbs.com video library today itself. Now, superior cerebellar peduncle. What are the fibers that are passing? Dorsal spinocerebellar tract is passing through inferior cerebellar peduncle. Ventral spinocerebellar through superior cerebellar peduncle. Dentato-rubro-thalamic tract. Dentate nucleus to red nucleus to thalamus to sensory cortex. That pathway which is connecting the cerebellum to the midbrain, midbrain to thalamus, thalamus to cerebral cortex, that passes through superior cerebellar peduncle. Then trigeminocerebellar tract in the midbrain you have a nucleus called mesencephalic trigeminal nucleus. So trigeminocerebellar tract. Then nucleus ceruleus, cerulocerebellar tract, superior cerebellar peduncle. Tectocerebellar tract from the superior colliculus, inferior colliculus. Superior colliculus is in the visual tract, inferior colliculus is in the auditory tract. Auditory pathway, they both tectocerebellar tract, also superior cerebellar peduncle. So that is a short story of cerebellum. But this should be an inspiration for you to go back to the online mbbs.com video library where AIMS में last 15 years, anatomy में what are the questions? NEET PG last 15 years, what are the questions? FMGE last 15 years, what are the questions on cerebellum? दिल लगा के रिविजन करना है PGI में last 15 years, what are the questions on cerebellum? So you have all these 30,000 MCQs are made available in the online mbbs.com video library, and our Sunday sessions are a way to inspire you, to know, to challenge you that these are the important topics. You have to be 100% sure before the exam and consume the video on the online video library. Now, Doctor, epiphysis, what are the types? There is a traction epiphysis, atavistic epiphysis, and pressure epiphysis. Now, Doctor, pressure epiphysis, where do you see pressure epiphysis? Head of the femur, condyles of the tibia, and the lower end of the radius. Traction. It provides attachment to the tendon, that is trochanter of the femur, tubercles of the humerus, mastoid process, they are all traction epiphysis. Atavistic epiphysis. Phylogenetically, an independent bone, which in the case of the man has fused to another bone. Coracoid process of the scapula, posterior tubercle of talus, os trigonum. Atavistic epiphysis. Aberrant epiphysis not always present. Only if you are a NEET PG topper, you have it. Head of the metacarpal, base of the other metacarpals, you have aberrant epiphysis. So, which is a atavistic epiphysis? Keep punching the answers, doctor. You need to be proactive with a seamlessly interactive session. That's what we should look for. Which is an atavistic epiphysis. Coracoid process is a atavistic epiphysis. The epiphysis which is there at the tip of the coracoid process is atavistic. Now, portal vein is the next hot area for the examiner. Portal venous system, the whole system is valveless. In adults, no valves. Portal vein is formed by the union of superior mesenteric vein and splenic vein. So from the spleen, the splenic vein and the superior mesenteric vein together will form the portal vein, and it will be heading towards the liver. Now, IVC, the right suprarenal vein drains into IVC. On the right side, suprarenal vein, adrenal, testicular, everything directly drain into IVC. At what level does it drain? It drains at the level of the 12th thoracic vertebra. Inferior vena cava about the thoracic duct, doctor. Thoracic duct. Do you still have the stream? I hope the broadcast is okay. Yeah, I hope the broadcast is okay, Doc. Now, how does the thoracic duct journey? So, doctor, this is the thoracic duct. It starts with a dilatation called cisterna chyli. And this is the left hemiazygos, accessory hemiazygos, and this is the azygous vein. Right? Azygous vein. So the thoracic duct passes, it crosses from right towards the left at T5 vertebral level. T5 vertebral level, it crosses from right to left. Then it will be further ascending up, close relation with esophagus, and ultimately the point where left subclavian, left internal jugular are having a confluence into the left brachiocephalic, that is the point where thoracic duct will be draining into, is what you need to remember. So this is a quick course of the thoracic duct. Mainly, you should remember T5. T5 is something that you need to remember, doctor. Okay? Now, ovulation is our next favorite area for the examiner. What are the coverings of the Graafian follicle? Theca externa, theca interna, granulosa cells. So you can see this is all theca externa. I'll take a different pen. I'll do one thing, doc. I'll just yeah, sometimes there will be a little broadcast disturbance. Okay, so doctor, these are the theca interstitial cells. This is the antrum, zona pellucida. Now the broadcast is okay, right? Good. Nishala Dahanayake. Nishala Dahanayake. Are you from Sri Lanka, doctor? Which part of the globe are you from? So, yes. You have Jonah pellucida, Cumulus oophorus, and the granulosa cells. Of course, this is called Theca externa. Theca externa. Very good. Nishala Dahanayake from Sri Lanka. What a great privilege to be having students across the countries. Now, doctor, Theca interna. And this is called granulosa cells and corona radiata. Okay, so this histological architecture of the Graafian follicle, you need to have a clear understanding, doctor. So what are the coverings of a mature or a Graafian follicle from inner to outer? So the innermost, you have the granulosa cells, right? Then you have theca interna, then theca externa, theca externa. So these are the coverings of a mature Graafian follicle is what you should remember. Primordial germ cell, from where does it develop from? It develops from yolk sac. The germ cells in the embryonic yolk sac, they differentiate in the gonads and they pass on the genome as gametes. So, yolk sac is the origin for our entire civilization. Primordial germ cells. After how many days of ovulation, implantation occurs? It occurs in 7 to 9 days. So, within 24 hours before ovulation, there is a surge of LH surge. Then fertilization 24 hours after ovulation, and it will reach the uterine cavity 3 to 4 days post fertilization. Otherwise 4 to 5 post ovulation. Then implantation occurs 7 to 9 days post fertilization. That is what you need to remember. Now, doctor, prostate is the next favorite area of the examiner. Where do you see a fibromuscular stroma? Fibromuscular stroma, we see it in prostate. So this is the prostate gland, panoramic view, where you are able to see fibromuscular stroma. These are columnar cells, right? Then, so this is the glandular parenchyma. So fibromuscular stroma is a feature of prostate gland. About prostate gland, there is a fibromuscular stroma and glandular tissue. Examiner tomorrow is going to give you this as a histological slide, asking you to recognize the prostate. Uvulophysicae is in which lobe of prostate gland? It is there in the median lobe. So the prostate gland is having a median lobe. You have a uvulophysicae. Because the bladder and prostate, they are in close relation, right? So the median lobe projects into the bladder behind the internal urethral orifice, and that leads to an elevation in the bladder called uvulophysicae. Right? And because of this elevation that it created, it will let the urine to collect behind that projection. That's the point you need to appreciate. Now, tonsil. What is the structure that you see in the lateral wall of the tonsillar fossa? It is a superior constrictor muscle. So to be very sure, three-dimensional anatomy of the tonsillar bed, doctor. See, This is the superior constrictor muscle we are talking about. It is between buccopharyngeal fascia and pharyngobasilar fascia. Between these two fascia, you have superior constrictor. Then here you have medial pterygoid. This is the angle of mandible bone. Then you have the masseter. And this is the styloglossus muscle. And this is the submandibular salivary gland. And this is the tonsil that you are able to see. And there is a lot of loose areolar tissue. Paratonsillar vein. This is a paratonsillar vein. So these structures, you should get a clear idea when you are looking at them. So a triangular tonsillar fossa. Triangular tonsillar fossa. On each side of the oropharynx between palatopharyngeal, palatoglossus arches, it contains the palatine tonsil. Is what you need to remember. Now, doctor, in anatomy, the favorite question of the examiner, what is the arterial supply of palatine tonsil? Lingual artery, facial artery, maxillary artery, they're all supplying palatine tonsil. So you should remember the main source of the blood supply is the tonsillar branch of the facial artery. Other sources are, what are the other sources? You have ascending palatine artery. This is the ascending palatine artery. This is the facial artery. Then you have the lingual artery and its dorsal lingual branches. They are supplying the tonsil. And this maxillary artery gives rise to greater palatine artery. Even that is also supplying the palatine tonsil. So, greater palatine artery, and from the carotid, you are having ascending pharyngeal artery. Even ascending pharyngeal artery sends a branch to tonsil. So, summarize, doctor. This facial artery's tonsillar branch is the main one. This is the external carotid artery. And ascending pharyngeal artery, which is the branch, is supplying. Then your ultimately external carotid divides into superficial temporal and maxillary. From maxillary, what is drooping down? Greater palatine artery, the branch of the maxillary artery, is also supplying the tonsil. That is what you should understand. So, the whole tonsil, the main supply comes from external carotid artery, is what you have to emphatically remember. So, you have the tonsillar artery, which is the branch of the facial artery, then ascending palatine artery, and small tonsillar branches come from the ascending pharyngeal, dorsal lingual branches of the lingual artery, greater palatine branch of the maxillary artery, and ascending palatine branch of the facial artery. They're all the ones which are typically supplying. Got it? Now, from where are the tonsils developed? They are developed from the second branchial pouch. Now comes another very interesting, very hot, high-yield area for your tomorrow's exam, doctor. You have a pouch 1, pouch 2, pouch 3, pouch 4. Eustachian tube and middle ear, pouch 1. Tonsil, pouch 2. Inferior parathyroid and thymus, pouch 3. And superior parathyroid, pouch 4. So this is the story of the various pouches. You have to be 100% sure for the tomorrow's exam. Similarly, branchial arches. First arch is mandibular, second is facial, third is glossopharyngeal, fourth and sixth, fifth is not there. Superior laryngeal and recurrent laryngeal, the branches of the vagus. And in the first arch, what do you have? medial, lateral pterygoid, masseter, temporalis, mylohyoid, antebellum, digastric, tensor tympani and tensor palatine. Second, S for seventh. Now, and occipitofrontal is platysma, stylohyoid, stapedius, auricular muscles, posterobelly, digastric. Third is glossopharyngeal and it supplies stylopharyngeus. And fourth and sixth predominantly supply most of the muscles of the larynx and pharynx is what you need to remember. Now, doctor, tracts. Lateral horn of the spinal cord. The spinal cord's lateral horn, right? Which level do you see? We see it in thoracic spinal cord. So you should have a little 3D view about the various structures. Cuneate fasciculus, gracile fasciculus. Gracile is more medial and cuneate is more lateral. They are called the dorsal columns which are bringing your vibration and touch, doctor. Between them, you have a intermediate septum. Then you have a lateral funiculus and there is a ventral horn, ventral funiculus, anterior white commissure. Then you have an intermediolateral column. This is what we are interested. Lateral horn, it is also called as. So this anterior horn, posterior horn, lateral horn. Lateral horn is also called intermediolateral horn. And where is it located? Thoracic and the first two lumbar areas only you have the lateral horn. That's what you need to remember. And what does it contain? Preganglionic visceral afferent neurons of the sympathetic nervous system. You know very well, thoracolumbar outflow is sympathetic. Craniosacral outflow is parasympathetic. Cranial nerves like oculomotor, facial, vagus, they are all carrying parasympathetic. So cranial output. Other is sacrum. At the sacral level also, you are having parasympathetic outflow. So parasympathetic is called craniosacral outflow, whereas sympathetic is thoracolumbar outflow. That's the reason it will be leaving out through this lateral horn. So that is the reason only thoracic part of the spinal cord and first two lumbar you find this intermediate column. Craniosacral outflow is parasympathetic preganglionic fibers. That's what you should remember. Taste fibers, how are they related? Taste fibers, they are related through nucleus of tractus solitarius. What does it contain, doctor? It is a sensory nucleus for three cranial nerves. S is 7th, T is 10th, N is 9th. So glossopharyngeal, vagus, facial nerve. For all the three, there is a common sensory nucleus which is called nucleus tractus solitarius. And the taste fibers coming from the tongue are relayed to this NTS. So anterior 2/3, 7th nerve will bring information. Posterior 1/3, glossopharyngeal will bring information. And they ultimately tell what is the taste. To the nucleus tractus solitarius is what you should remember. So you should know, doc, that you are having the tongue here, nucleus tractus solitarius, then you have the thalamus, right? Thalamus, ultimately, where does the reporting happen? Thalamus reporting happens to the insula. Insula. So this is how the taste is being reported to the brain. Now what is the weakest support of uterus? Weakest is weakest is always the broad ligament. So uterus has pelvic diaphragm, perineal body, urogenital diaphragm. They're all the supports of uterus. And secondarily, it is also supported by the broad ligament of uterus, which is a peritoneal condensation. Now, let us look into the various segments. Uterosacral ligament from the posterior cervix to anterior face of the sacrum. Cardinal ligaments are all lateral from the side of the cervix to ischial spine. Pubocervical is from the side of the cervix to pubic symphysis anteriorly, which is not a true support of uterus. Infundibulopelvic ligament is not a true support. So the suspensory ligament of the ovary, also called infundibulopelvic ligament, is a fold of peritoneum that is extending from the ovary to the wall of the pelvis. So you have the sacrum and the pelvis. So ovary to the wall of the pelvis. You have the infundibulopelvic ligament. Otherwise, uterosacral, pubocervical, transverse cervical, they're all the true supports of uterus. Now, what are the contents of the broad ligament? You have to be very sure. Typically, it is the hypogastric nerve is not a content. Ovarian artery, parafuron, and ligament of ovary. They're all contents. So, doctor, have a three-dimensional view. Anatomy is all about, doctor, how much of 3D view you have, you are a good anatomist. So this is the fallopian tube, this is the suspensory ligament, the ovary, this is the utero-ovarian ligament, this is the broad ligament, is what you have to emphatically remember. So what does broad ligament contain? Remember broad. B, bundle. What bundle? Ovarian neurovascular bundle. R, round ligament. O, ovarian ligament. A, artifacts like vestigial structures, periferon, etc. And duct is a oviduct, fallopian tube. So these are the contents of the broad ligament, is what you should remember. Now comes the vagina. Where are the Bartholin ducts? Bartholin ducts are typically at the junction of middle 1/3, posterior 1/3 of the labia majora junction. So this is the external urethral orifice, this is the vestibule, and here you have the duct of Bartholin glands, and these are the Bartholin glands. And where is this location located, doctor? Labia majoras. You can divide the labia majora into 3 1/3, doctor. 3 1/3. First 1/3, second 1/3, third 1/3. Between second, you have to properly divide. So between lower 1/3, middle 1/3 junction, you are having the ducts of Bartholin's glands, is what you should remember. Bartholin gland is 10 mm, 1 centimeter in diameter. It contains racemose glands, and their acini are lined by low columnar epithelium. And the duct of it is about 2.5 centimeters, 25 mm. And it runs forward, inward to open into the vestibule, just external to the hymenal ring. That is what you need to remember. Now, which structure is related to the lateral wall of the vagina and uterus? Ureter. Very close relation with McEnroth's ligament. So you should remember that the ureter is passing very close to the uterine artery, lateral to the uterus. Paraduodenal recess is associated with which vessel? Inferior mesenteric vein. So this is the duodenum, doctor. The third part of duodenum crossed by the superior mesenteric vessels. And here you have a recess called retroduodenal, behind duodenum. Then this is superior duodenal recess, inferior duodenal recess, and paraduodenal recess, and it's in a close relation with inferior mesenteric vein is what you have to emphatically remember. So the inferior mesenteric vein lies in the paraduodenal recess. Superior mesenteric vessels lie in the mesenterico-parietal fossa of Valdea. And there is one superior iliocecal recess between ilium and cecum. There you have a branch of iliocolic artery. So that is a quick story, doctor. So I hope you all enjoyed the first part of our discussion. Almost 4 hours we have spent together. So doctor, we will take a quick lunch break and we will rejoin at 2:30 p.m. Right? So please don't forget to re-log in. Right now I will be stopping the broadcast, and tell all your friends also to join for the discussion at 2:30. Once more, I will give you 30 questions. 30 questions. After 30 questions, there is a discussion. Then 30 questions, discussion. 30 questions, discussion. So 4 rounds of tennis. Once we play, we are done. Most of the issues in anatomy, I'll try to complete in this every subject in about 8 hours. But the whole idea is, I want to inspire you guys to go back to the onlinembbs.com video library and do a more extensive revision. Have your own handwritten notes for the last moment preparation, right? So that is most important and the best way that you can be able to leverage from all these sessions. So we will all meet sharp at 2:30 p.m. Another 1 hour, right? Have a nice lunch, enjoy, and then we will come back in a postprandial drowsiness. I will take away all that drowsiness. Have a great afternoon. See you back.